Welcome to the online bariatric treatment seminar presented by Grand Health Partners and our participating hospital systems throughout West Michigan. My name is Dr. Eric Crable, and I am one of the metabolic and bariatric surgeons dedicated to helping patients on their journey to a healthier life. The purpose of this video series is to introduce prospective patients to our comprehensive weight loss treatment program. We wish to help you and your loved ones understand that obesity is a disease, and we often need to use many tools to treat it successfully. Weight loss surgery, also known as bariatric surgery, may offer the most benefit to your overall health when traditional weight loss methods have been unsuccessful. Our primary goal is to help you lose weight and improve those health conditions that are often caused or worsened by obesity, such as diabetes, high blood pressure, high cholesterol, heart disease, joint pain, sleep apnea, and even certain cancers. We often describe your path to weight loss as a journey, and we will be with you every step of the way. We provide a multidisciplinary approach to treatment with our staff of doctors, surgeons, physician assistants, dietitians, as well as behavior and exercise specialists. Since 2008, we have served over 15,000 patients and counting at Grand Health Partners. Our talented group of surgeons have had extensive training and experience in advanced laparoscopy and robotic surgery. We've also earned the recognition by the American College of Surgeons as a center of excellence at our hospital locations. This assures patients we are providing the highest quality care in our clinic and hospital. So are you a good candidate for surgery? We recommend you check with your insurance company first, but most health insurance providers in Michigan cover this form of treatment. In general, you need to be over the age of 18 with a BMI of 40 or higher, or a BMI of 35 to 39.9 with other medical complications. If you are unsure of your BMI, please talk to your doctor or use the BMI calculator on our website. You also need to be relatively healthy psychologically and be committed to making lifestyle changes. If you meet these criteria or simply want to learn more, please keep watching the series of videos that follow. You will also learn about our non-surgical weight loss options that incorporate healthy eating plans, personalized exercise routines, behavioral therapy, and even prescription medications to help control hunger and appetite. Next, you will hear more from my physician and surgeon colleagues about how to prepare for a healthy life before and after your procedure, insurance requirements, determine what surgery may be right for you, and finally, how to get started. And please remember, our main goal and purpose is to improve the overall health and lives of our patients. So, please keep watching and let's take the next step together.
So how do we treat obesity? We think of obesity care or overweight management as a continuum of care that includes lifelong management, lifelong support with our team of healthcare providers. We often will start with lifestyle modification, things like nutrition support. In our office, we'd have appointments with a registered dietitian, and then we'd review your food logs, review things like how are you getting enough of your nutrition? Are you getting your macronutrients? Things like getting enough protein, getting your fiber, things that keep you full. We'd often get you in with our exercise physiologist to come up with a plan. Exercise can improve your cardiovascular fitness. It can help maintain and build lean muscle. It can improve bone health, and it can lessen depression and anxiety. But we don't necessarily want to start where we end up with exercise. So we need to come up with a plan that gradually increases as your stamina and ability to move increases. So we want to customize that. Behavior changes. One of the most important things with weight management is changing our behavior. And we have behaviorists and counselors on staff here that are very skilled at addressing your relationship with food, help you with tools to address emotional eating, and helping you use the support system of your own friends and family and the care team that we provide to improve your overall weight management. Next, we might move on to something like anti-obesity medications, or AOMs. These are tools that we use along with lifestyle changes to help with hunger and cravings and triggers to eat more than we should of certain foods. They work in multiple ways depending on which medication we use, and they can help give anywhere from 5 to 15 and maybe even more body weight reduction over about a year when combined with lifestyle changes. So these are just an additional tool that we'll use on top of the other things that we're doing to manage weight. It's important to check with insurance and check your coverage to find out what your options are before your appointment to discuss starting AOMs. Medications currently include Wegovy, Saxenda, Qsymia, Contrave, phentermine. There is another one called Plenity that is often not covered by insurance. And sometimes in obesity medicine, specialists will use generic medicines similar to the above FDA-approved medications in similar dosing when we don't have great coverage there to improve costs. AOMs can be used at several points in the obesity treatment continuum, including after bariatric surgery, either to get it past a weight loss plateau or help with regain. So again, this is a continuum of care, and it doesn't just end with bariatric surgery, but we want to help you throughout that process. At Grand Health Partners, we offer medically supervised weight loss programs. We have 2 different nutritional programs, one using our food in our store at about 900 calories per day. That's called the Getting Healthy 900 program, and one using grocery store food, and you're welcome to supplement our food in the store if you'd like. Either way, we're trying to improve that nutrition and modified diet, but it's a bigger piece than that. We have weekly classes that are taught by the dietitian, exercise physiologist, and then usually 2 out of every 4 classes is taught by the behaviorist to help you with long-term behavior changes for long-term weight management. These classes are done in a group setting, so you'd have the help and support of your peers, and it is a 6-month program that allows you to then move on to what we call our Living Healthy program for lifetime support. The first step in any medical program and any surgical program is to make an appointment with either one of our bariatric physicians or our bariatric PAs so that we can get a complete history, talk to you about your health concerns, find out what your goals are, do a physical exam, and make sure that we are doing everything we can to optimize your success in long-term weight management.
According to the National Institute of Health guidelines, people that qualify for bariatric surgery are 18 years of age or older. They have a BMI of 35 to 40 with at least one comorbid condition, or if they have a BMI over 40, they do not need to have a comorbid condition to qualify. Our office staff will be able to assist you in determining your exact criteria for surgery, should you have any questions about insurance coverage. There are a number of preparatory appointments before elective bariatric surgery. Your first appointment will be with one of our bariatricians for a complete history and physical. With the information from this appointment, we will assist with coordinating and determining any necessary preoperative testing from specialists such as cardiologists, endocrinologists, or pulmonologists. All patients will also meet with our behaviorist, dietitian, and exercise physiologist as part of the insurance requirements. Laboratory studies for vitamin and mineral levels will be checked, and if necessary, any supplements will be started before surgery. As part of medical testing before surgery, patients undergo an upper endoscopy to evaluate their stomach, esophagus, and small bowel for any signs of inflammation, ulceration, or evidence of a hiatal hernia. We are also able to provide screening colonoscopies and do require all routine screening tests to be up to date based on age and gender before our elective surgery. Prior to surgery, as you have appointments with our dietitians and exercise physiologists, you will begin your journey by learning about proteins, fats, and calories in the foods that you consume and begin changing your diet along with starting a physical activity routine. All patients are required to quit smoking prior to surgery as it is connected to poor surgical outcomes and is the #1 cause of premature death in America. After patients have obtained insurance authorization for surgery and scheduled a date, they begin a 2-week preoperative diet. The purpose of the preoperative diet is to promote weight loss, which will shrink the liver in volume. This increases the visibility for a minimally invasive laparoscopic surgery and reduces the risk for surgical complications.
The 2 most common bariatric procedures that we perform are the sleeve gastrectomy and the Roux-en-Y gastric bypass. We have performed over 15,000 bariatric cases, and have extensive experience with performing these procedures. They basically work by creating smaller, lower capacity stomachs. In the normal stomach, there are receptors that sense pressure and stretch when food fills the stomach. Most of these are located near the top of the stomach. In a normal stomach, immediately upon eating, the stomach relaxes and stretches, increasing the capacity of the stomach. It takes more food then to trigger the stretch receptors to engage fullness. If someone overeats for a long time, the stomach actually gets bigger at baseline so that it takes more food to get the same amount of fullness as smaller portions caused before. These procedures take out the stretchy part of the stomach, so less food causes more fullness. In addition, this stretch has been shown to increase metabolism. So less food causes more satiety or fullness and increases metabolism. This also leads to what I call the kryptonite of bariatric surgery. Liquids with calories pass through the stomach rapidly and do not initiate as much fullness or as much of a metabolism boost. We have a multidisciplinary team involved in our Center of Excellence, and we will spend a fair amount of time helping you get the best results after surgery so that you can get healthier and be more active. The sleeve gastrectomy is our most common procedure because it is the safest and doesn't rearrange the GI tract. The sleeve gastrectomy is not some sleeve material being put over the stomach. Instead, it is a stretchy part of the stomach being removed to create a skinny stomach that resembles a sleeve. It is the safest procedure that we perform and has been reported to be safer than gallbladder surgery, hip or knee replacements, or even C-sections. Most people lose around 60 to 70% of their extra weight by 2 to 3 years out. The sleeve has no malabsorption and has the lowest vitamin requirements after surgery. The Roux-en-Y gastric bypass, on the other hand, makes a small stomach pouch, but also rearranges the small bowel. This can be beneficial in some instances, but also introduces potential issues related to the bowel rearrangement. Malabsorption, vitamin deficiencies, ulcers and bowel obstructions, along with dumping syndrome, are a risk in the Roux-en-Y gastric bypass. Also, the rearrangement can make it difficult to get to some parts of the GI tract. Despite this, the Roux-en-Y gastric bypass has been around for a long time and is often felt to be better for patients that have gastroparesis, which is a poor functioning stomach, or in some cases of diabetes and severe reflux. It is important for us to engage with you in carefully reviewing your medical history and discussing the pros and cons of the different surgeries to determine which is the best procedure for you.
So here's a diagram of the duodenal switch. My partner, Dr. Baker, already discussed the sleeve gastrectomy where we remove part of the stomach and we leave this tube that we call a sleeve, and I'll refer you back to his section if you want to learn more about that. But the duodenal switch does have a sleeve, but then what we do is we divide part of the intestine called the duodenum. So you can imagine that this part used to be connected to that part, and that's called the duodenum, but we're going to switch it up. So we have to divide the duodenum, and then I come way downstream and I find the beginning of the colon, and I'll measure the intestine back, and this is what's called the common channel. And we can vary the length of the common channel with the duodenal switch based on how much malabsorption or absorption of nutrients that people are able to take in. But then we divide the intestine, and we'll bring that piece of intestine up and make a little connection here, and we have to make another connection downstream. So by doing this, food goes down this channel, but juices from the liver called bile, which we need for fat absorption, and juices from the pancreas that's not drawn on here, the pancreatic juices help us absorb protein. They're going to empty into this channel, but food's not going to be along that channel, and it's not until we get way down here that the food from above mixes with the juices, and then over the length of the common channel, we're going to absorb nutrients. So with this operation, people aren't eating as much and they're not absorbing as many calories, so they have better weight loss with this. As a matter of fact, they actually have better remission of cholesterol issues and high blood pressure as well as diabetes, and so that's all really, really good. Unfortunately, it comes at a price, and the price is we're bypassing where iron and calcium are absorbed. So we actually have to supplement iron and calcium. but that's not the only nutrients. We also are impeding the ability to absorb vitamins A, D, E, K, zinc, copper, a lot of different vitamins. And so what we have to do is put people on supplements, and we have to use a lot of supplements. So it probably costs about $100 to $150 a month just in vitamin supplements for patients after they have a duodenal switch. And sometimes they actually have to take those supplements up to 5 times a day, and even with that, they might not absorb it appropriately. So on occasions, we'll have to do things like iron infusions. Sometimes people actually have to buy vitamins that are in a patch form, and they wear it as a patch. So there's a lot of different things that we have to do to make sure that their nutrients are where they need to be. And they also have to have more common or more frequent blood draws and lab checks to make sure that we're keeping up on all their nutrients. The other thing to know about the duodenal switch is people don't absorb sugar as well. And if they eat too much sugar, then ultimately what they will get is really, really bad smelling gas, and they will also get diarrhea. And so these patients also have to follow a lower carbohydrate diet. So that's the duodenal switch. And we're also going to talk about the SADI. Now, I don't have a diagram of the SADI, which is a single anastomosis duodenal ileostomy, but what we do with the SADI is we actually don't divide the intestine downstream. So what we do is we just bring a loop up, and we connect that loop up to the duodenum. Now, the benefit of the SADI is that it's an easier operation. And that easier operation means it's a faster operation, but there's a downside with it. And the downside is because we're not dividing the intestine, the juices from the liver and pancreas are actually going to be in contact with food for a longer distance. And remember I talked about we can vary the length of the common channel with the duodenal switch. With the SADI, we tend to keep that at a standard length, which is roughly about 9 feet in length, or 300 centimeters. We usually will measure it in centimeters. And so that's really a big difference. The SADI is a newer operation. We don't have as much data on it, so it's less frequently performed than is the standard duodenal switch. On this segment, we're actually going to talk about revision surgery. And sometimes we do procedures that don't have the outcome that we're looking for, and we sometimes will have to revise an operation to a different operation. Examples of this would be the laparoscopic adjustable gastric band, what a number of people know as the lap band. And with the lap band, sometimes people will either not have effective weight loss, or they might have some reflux or difficulty swallowing. And what we have to do is convert that band over to another operation. So some of those operations would be converting it to a vertical sleeve gastrectomy, to a Roux-en-Y gastric bypass, or to a duodenal switch. And you can go back and look at all those sections on each of those procedures to know a little bit more about it. The other thing is sometimes with the vertical sleeve gastrectomy, people will have significant reflux after that, and we might have to actually revise a sleeve over to a Roux-en-Y gastric bypass, and that's a better anti-reflux operation. The thing to know about revision surgery is it's harder, and the reason why they're harder procedures is because somebody's already previously had surgery, so there's going to be scarring related to that. There's some literature to suggest that anytime we do revision surgery, it carries a higher rate of a complication, and some of the literature says that that rate is 4 to 10 times higher than the original procedure. Fortunately, within our group, we're not seeing rates that high, but it is important to know that it is a more complex operation, and therefore it does probably carry a slightly higher risk associated with it. And the revision surgery is a very tough topic. I can't cover everything just in this short video, but if you're someone who's interested in revision surgery, we'd want to meet one-on-one so we can go over the particulars in regards to your history and what we have to offer with that.
Hi, I'm Dr. Jeremy Bushman, one of the surgeons here at Grand Health Partners, and I'm going to be talking about post-operative recovery. This is a topic we get a lot of questions about. How long am I going to be in the hospital? How long am I going to be off of work? So we're just going to cover that briefly today. Hospital stay is usually one night. You're going to be sore, you're going to be tired after surgery, and also nausea is very common. That's why we keep you for a night. We got a lot of great medicine to help, and it's also just giving your body time to get adjusted to that new, smaller, tighter stomach. Most people home the next day, usually in the early afternoon, and so that's our plan unless something would change that plan. Most people end up taking about 2 weeks off of work. I get a lot of patients that call me after a week and they say, hey doc, I'm getting my liquids in, I'm getting my protein in, I feel good, I'm walking, I've got minimal pain, can I go back early? Yeah, absolutely, sure. In fact, a lot of patients that are staying home and working from home, that's what they end up doing. I would say still on average about 2 weeks is a pretty good amount of time to take off of work. It's usually not the soreness so much as it is tiredness. You're definitely going to feel more tired after surgery because your body's using a lot of extra energy to heal. A couple of restrictions after surgery. Activity, I want you to walk. We all want you to walk because walking's great. It helps you heal up, heal faster, prevents blood clots. What we don't want is real heavy activity. Crunches, sit-ups, weightlifting, workout type stuff. We just want you to wait about 2 weeks before you do that. Showers are good. Just don't sit in water. No baths, no swimming, no whirlpools. If you sit in water, that's going to increase your risk of infection, so we avoid that for about 2 weeks. Biggest change after surgery is diet, not because we want to be mean, but because we want that stomach to heal. If you eat solid food too soon, it's going to clog up the stomach and make you feel pretty bad. And so that's why we stick with liquids or really soft stuff for about 6 weeks just to let things heal up properly. In general, the recovery is fairly short, again about 1 to 2 weeks off of work, and really 6 weeks until we start seeing a lot of the benefits. Losing weight, losing clothes sizes, getting off medicines, gaining energy. That's why I love seeing people at 6 weeks, and pretty much by then, you're just ready for your new life.
All of the requirements and appointments we have discussed can seem overwhelming and confusing, and this is why all of our patients are assigned a care coordinator. Your care coordinator will assist and guide you throughout your surgical journey and ensure all requirements are met. We are committed to your success and will provide you with the excellent care you deserve.